Good evening, everyone. I'm Namu Budu, Membership Manager at CUH. Apologies for the delay. We were experiencing some technical issues, but we got there in the end. Thank you so much for joining us this evening for this informative lecture around anti-obesity medications. Without further ado, I'll hand over to Robin Stevens, our patient governor and host for this evening. Robin, over to you. Thank you.
Thanks, Sabu. Thank you. And thank you for waiting. I'll keep my introduction very short because the main purpose of the evening is to listen to Professor Salaf Faruqi. But just briefly, my job is just to explain what we're doing, but also to encourage you, if you're not members, to become members of the COH. The Cambridge University Hospitals membership group is free. It's free to anybody over the age of 16. The patients, carers, and members of the public can become members. We need members' opinions to help us to improve our hospitals while offering the NHS discounts and health related events such as this event tonight, the Medicine for Members lectures, listening sessions and other experiences. So we'd very much like to encourage anybody on the call who isn't a member to join. Also, just to bring to your attention that there are governor elections which begin on Monday the 26th of February, and we have 8 vacancies if anyone is keen to become a governor. I've been a governor for 9 months, and I can certainly recommend it. I've met a lot of very bright people. There's a lot more than I knew before. If you are interested in the elections or actually becoming a member, please look at the CUH website, which is www.coh.nhs.uk. So please get involved with the local process and join. So tonight's topic is a medicine for members, dawn of a new era for anti-obesity medications. It's hard to think of a more important issue, I think, than obesity as we sit here. The issue it has on heart disease, diabetes, hypertension, joints, and also its effects in terms of we can't possibly help to put all the money that needs to go into the NHS if we can make people fitter, healthier. That hopefully will reduce demand. Salaf Faruqi has asked me to keep this very short, and I will do because of time. But just to say that she's a consultant physician at the CUH and a professor of metabolism and medicine at the University of Cambridge. She is an international leading clinical scientist who has made seminal contributions to our understanding of genetic and physiological mechanisms that underline obesity and its complications. We'll have half an hour of the presentation, perhaps slightly less. After that, there'll be time for Q&A. Do put your questions into the chat box. If we can't deal with all the questions during the session, we can answer them afterwards. We've got your email addresses, and we'll be able to answer those. And then at the end, we'll after the presentation, we'll make the presentation available by email as well. So now over to you, Professor Faruqi. We very much look forward to hearing your presentation and thoughts and insights. Thank you.
Great. Thank you very much. Can you hear me okay?
Yep, we can.
Fine. And can you see my first slide?
Yep, we can.
Okay, great. Apologies all for the lengthy delay. Hopefully this will work and you'll be able to see my slides and hear what we're going to talk about. So I'm very excited to talk to you today about some of the work that we've been doing. We're based in the Institute of Metabolic Science, which is just near the treatment centre entrance of Addenbrooke's. And there we've been undertaking research for many years now into trying to understand the health problems associated with obesity and how we can help. So for a long time, really, we've been thinking in the way that is depicted on this cartoon on the left, that really all we have to say to people who struggle with their weight is go on a diet, hopefully you'll lose a bit of weight, and really we've had very little to offer beyond that. Now you will have heard, of course, that there is now some very new drugs for the treatment of obesity on the horizon, and indeed they've literally very recently over the last few months been licensed for use in the UK. They've already been in use in the US, and they're transforming the lives of patients with obesity. So I'm going to talk today a little bit about some of the science underlying obesity, how that science has informed the development of these drugs and how we understand they work, and then really end with where I think the treatment of people with obesity is going and how that might impact on health policy. So just to start with, what is obesity? What do we mean by obesity? And obesity is when you have an excess amount of fat that adversely affects your health. And the way that we define obesity is using body mass index, or BMI, which is weight in kilos over height in meters squared. And a BMI of 30 is used to define obesity because we know at that point it's associated with worsening health. Now, the map on the right shows you the prevalence of obesity using this BMI cutoff around the world. And you can see really that globally, we are facing huge problems with obesity. And in the UK, 25% of adults have obesity, and over 50% of the population either is overweight or obese. So it's a huge clinical problem. And the reason that we worry about people having obesity is because of the health consequences of having too much fat in the body. And those health consequences really affect many other systems of the body. We're very familiar with the fact that as people gain weight, you increase their risk of type 2 diabetes, high blood pressure, and indeed heart disease. Obesity is actually the single biggest risk factor for heart disease, even more so than smoking. Now, obesity affects the liver. Generally, people will put fat into the liver. In some people, it sort of stays there, but in a proportion of people, it goes on, becomes inflamed. You can even get fibrosis and indeed cirrhosis of the liver. And obesity is overtaking alcohol as a major cause of chronic liver disease and the need for transplantation. Now, what's often perhaps less well known is that obesity is also a major cause of cancer. In fact, it's overtaking smoking as a major driver of cancer, and there are quite a few different cancers that are associated with obesity. Obesity can also affect the brain, and there's reasonable evidence now that obesity can also increase the risk of dementia. And as well as these major conditions, there are lots of other clinical problems that people with obesity face, from infertility, kidney disease, asthma is more common in people with obesity, and many other conditions, including depression. Of course, it's really important, I think, to remember that as well as these physical and indeed mental health problems, people with obesity often face a lot of stigma in society, where they're often blamed for gaining weight excessively and harming their health. Now, it's not all doom and gloom, because if we can help people to lose weight, we can substantially improve metabolic and cardiovascular outcomes and their health. Now, this slide is quite complicated, but it depicts the fact there are quite a few different health consequences, as I've outlined. But even if you lose 5% of your weight, you can see benefits on health. So with 5% weight loss, you actually see improvement in the level of glucose in someone with diabetes. You can improve their blood pressure and also their cholesterol and their lipids. If you get a sort of 10% weight loss, you start having an impact on people's function, for example, on sleep apnea, on arthritis, and also on the progression of liver disease. And if you get more than 10 or even 15% weight loss, which we know from surgery data, that you start getting substantial effects on mortality, in particular on cardiovascular mortality, and indeed on healthcare costs. So clearly, it's important that we try to tackle the problems associated with obesity. And one of those problems is clearly, how do we find effective ways to help people to lose weight? But to be able to help people to lose weight, we need to understand what's driving the weight gain in the first place. So this sort of slide summarizes a rather simplistic view that we've had in the past of what's the drivers for obesity. On the left, you can see, a lot of people think it's very straightforward. It's a lifestyle choice. As Homer Simpson shows here, people must be eating a lot of extra calories, and it's basically a lack of willpower that's driving their obesity. So if that's the case, then it's your fault. Well, okay, people are eating more. We are generally eating more food, but actually the data shows that it's actually a small increase in the amount of food that we're eating over the number of calories that we burn. It's actually enough to explain the change in the BMI of the population. It's quite clear that what's changed over the last 30 years, when the prevalence of obesity has really skyrocketed, has been our environment. It's the access to food that's cheap, high in calories, very palatable, and easy to obtain, that's really the major driver for us generally eating more calories than we burn. And of course, we're burning less because we're less active, both at work and in leisure time. And if you think about that, you could say, well, okay, it's society's fault. But there's another viewpoint, and I'm going to show you some data on this, that actually says, well, what if it's genetic factors that are contributing to the rise in obesity? And of course, if that's the case, then it would be your parents' fault. So what does the evidence actually tell us? Well, actually, the evidence tells us that clearly obesity is strongly influenced by our environment, and also by social factors. It's important to note that people who live in less well-off communities are twice as likely to have obesity as people in more affluent communities. And all of these environmental factors just tip the balance between the calories we consume and the calories we burn, which really leads to people gaining weight. But as you can see from this sort of schematic of the people of different sizes, is that within any given environment, there's a lot of variation in how much weight people gain. Some people will gain weight very easily, have a tendency to gain weight quite easily, but other people can eat what they like and they stay slim. And what we now know is that variation in weight in the population is strongly influenced by our genes. If you look at the photographs on the right, you can see that there's always been some people who've been predisposed to severe obesity. If you look at the lower right panel, you can see the twins. And here what we see is that identical twins tend to have a very similar body weight as adults, whereas non-identical twins can be quite different. And really what that shows us is that our genes have a strong role to play in our weight. Now, the dice at the bottom really depict a summary of a large amount of work, and obviously ourselves and other researchers in Cambridge have had a major interest in this area for over 20 years now. And we now understand a lot about the genetic contribution to weight. And what we know is that for some people, these genes can add up and they increase the risk of developing obesity, particularly in an environment where that becomes very easy to do. In a particular group of people, and it might be something like, at least 5% of people or 10% of people have specific genes that are faulty and can cause them to develop severe obesity. In other people, we now know there are genes that protect them from developing obesity, even when they're in an environment such as we have now. And indeed, there are also genes that allow some people to stay thin. And that's been a really important finding, is that there are genes that protect people and keep them thin. So what are these genes and where do they work and how are they affecting our weight? Well, they're working on a really critical part of the brain called the hypothalamus. And the hypothalamus is sort of just behind the nose, and it's a part of the brain that's fundamental to keeping our body in a stable situation. So that means temperature regulation, the regulation of growth, but also the regulation of weight. And the hypothalamus receives signals from hormones and from inside the brain, and then changes those signals to alter the neuronal circuits in the hypothalamus to keep our weight stable. Now, for most people, weight is kept stable over a long period of time, but the lower panel depicts a very nice schematic which allows us to understand that there is something called a set point or a set point range. And what that means is that most people will operate within a certain weight range. Sometimes they'll gain a bit more weight, sometimes they'll lose a bit more weight, but that's actually the job of the hypothalamus, is to keep them in that range. And what happens is that our genetic factors influence where your range is. Are you tending to be on the heavier side? Are you tending to be in the middle? Or are you tending to be pretty slim? So our genes influence the system that we have for regulating weight. Now, what we now know about that system is some of the actual components of that system and how it works. So the cartoon figure on the left is really depicting some of those signals. So we now know we have hormones that come from fat tissue, which we used to think was there just to store extra calories. But actually our fat makes hormones such as leptin, which then go to the brain and tell the brain about how much fat we're storing and how many calories we have on board. We also get signals from the gut. So we get signals that are hormones, but also neural signals that telling our brain about the amount of food we've eaten and that we must be full because we've eaten a meal. And our brain is really putting all of this information together to regulate our appetite over a long period of time. And we learned, because we identified children who were lacking the hormone leptin, that if you don't have any leptin at all, your body thinks you're starving. And these children would be constantly hungry and gained a lot of weight. And we were able to treat them with leptin and restore their weight to normal. And through studies in these children, we learned that actually what leptin is doing is pulling together lots of other signals to control our appetite. Now, leptin is also showing us that food can be very rewarding. And that's really relevant when we think about a common situation, which is when people lose weight. So on the bottom right, you can see a little plot here of what might happen in someone who goes on a diet and loses weight. Now, when you go on a diet and you lose some weight, your leptin levels will fall. And that sends a signal to the brain, telling the brain that you're starving and that you need to eat more. And that's why people often describe that they're craving food and they want to eat more food. Traditionally, doctors have tended to say that's a lack of willpower and you need to just kind of control that desire and stick with your diet. But actually, we now know that's a hormonal signal telling you to eat more and actually making you prefer high-fat food that's very rewarding. So actually, it's very difficult to maintain that degree of dieting. And this is often why people rebound and do yo-yo dieting, as we often call it, and regain the weight. Now, this is just a simplified view of what happens in the brain when leptin actually gets there. And leptin goes on to act on different neurons or nerve cells in the brain, which have various functions. We actually have a very strong system telling us to eat. And that's this neuropeptide called AGRP, which basically will tell you to keep on eating, and it's there to prevent you from starving. Now, on the other side, you also have some neurons that are telling you to stop eating after a meal. They're described in red here, expressing something called POMC. And they go on and they converge and they act on another set of neurons where you have another gene called the MC4 receptor. And this is really a critical gene because it pulls together these opposing signals to regulate what you eat. And essentially, MC4 acts like a brake on hunger. And so after a meal, it's activated and it sends a signal to stop eating. And what we find is that some children who gain a lot of weight will have a genetic problem stopping them from making leptin or from leptin to work properly, or indeed many of the different genes that act in this circuit. So that proves that this circuit in the brain is critical for regulating our weight. MC4R is really a very critical gene, and it is actually the source of the focus of some of the drugs that are now becoming available, because there's a lot of people out there who have small changes in this one gene. So 1 in 300 people will carry a small change in the gene. It's a bit like a spelling mistake in a very long word. And that small change is enough to stop the gene from working. And if the gene doesn't work properly, just this one gene, that's enough for a person to gain weight from early childhood. Here's data from our colleagues in Cambridge working with colleagues in Bristol who showed that basically, even if you have one small change in this gene, you will tend to gain weight from early childhood and be substantially heavier by adulthood, just down to this one gene. On the other hand, we showed that 6 in 300 people carry a different type of genetic change in MC4R, which actually makes it super powerful. It makes the gene work very well. And that increase in the function of the brake means that the brake is always on, they're not really hungry, and these individuals are protected from obesity and type 2 diabetes. So you can see by focusing on one gene, how genetic changes will influence a person's appetite and their weight, and indeed their risk of obesity and diabetes. Now, what we've also learned is that these pathways in the brain regulate not only how much we want to eat, how full we feel, and our cravings for food, the fact we find food to be rewarding, but they also affect our preference for food. So in this particular study, we tested work because it had been shown in animals that this pathway is involved in food preference. And what we find is that people who are lacking this MC4R gene, the brake on hunger, have an increased preference for fat as opposed to a preference for sucrose. So what we did was we offered people a large amount of chicken korma with varying amounts of fat content, and we found that they actually preferred the high-fat meal without realizing it. That was different from people who were normal weight or people who had more regular forms of obesity. And people who had a faulty MC4R gene, whilst they really wanted the high-fat chicken korma, they really didn't want high-sugar food. So showing a real divergence in food preference. Why is this important? Well, it's important because this pathway, as I mentioned, is there to defend against starvation. And if you're starving, you want to eat more food, but actually you want to eat more fat because fat has more calories and you can keep storing fat. So it's a good thing to want to do. And ultimately what this shows us is that actually our appetite, which we've traditionally tended to think is just entirely down to voluntary control, as shown by Homer Simpson on the left here, is actually quite complex and is hardwired in the brain and influenced by our biology and by our genes. So the illustration on the right shows that actually the circuits in the brain control our food intake, how rewarding food is, and when we feel full. Now, they receive signals from the body, from various hormonal signals, but they also receive, they're activated by external signals in the environment. So the smell of food, when you read a menu, if you taste something, if you see something visually appealing, or even if the fact that you realize that a lot of food is available, for example, in a buffet, all of those signals go into the brain and act on these pathways. So we're not quite as in control of our eating as we like to think. So we have all of this science, and this science has really led us to understand the system in a lot of detail. Of course, for a long time, and certainly for pretty much most of my career, we've had very little in the way of treatments for people with obesity. And that's partly because we didn't really understand the science very well. What's really changed over the last few years is a really big body of evidence allowing us to understand these pathways and how they can be targeted. And that's really led to the transformational development of these new drugs. So what are these new drugs and what do they do? Well, there's been a lot of excitement about them because they appear to be very effective in clinical trials. So I'm just going to return to that schematic on the right, showing, if you like, the system that we have for regulating our weight in a simplistic way. So we have the brain, and it receives signals from our fat, such as the hormone leptin, and it receives signals from the gut in relation to meals. And those can be signals from the nervous system through the vagus nerve, but also hormonal signals. Now, these new anti-obesity medications are based on a group of molecules shown here in the blue, often called incretins. And they were given that name because they're made by the gut and they go to the pancreas where they boost the release of insulin. So over many years, researchers were working on these molecules to boost the amount of insulin that can be made to treat people with diabetes. And what they found is that these drugs were first licensed for the treatment of diabetes, and they worked, but they also actually allowed the people to lose weight. And so people started looking into, well, actually, could these drugs be used to treat obesity, even if people don't have diabetes? And that led to our understanding that actually these molecules, as well as working on the pancreas, they work in the brain. They go in the bloodstream to the brain, but actually there are also, some of these are produced in the brain directly, and they can act on receptors there to regulate our appetite and reduce appetite and make food less rewarding. And what we now have is a whole set of drugs that target the receptors for GLP-1, for another hormone called GIP, and also for glucagon, which is made by the pancreas. And this is really the reason for the excitement. This is just a graph showing the amount of weight that people have lost in clinical trials with different sets of drugs over time. A few of the drugs that we had over the last 20 years were possibly only giving you about 5% weight loss at best. What we now see is about 15 or indeed 20 or 25% weight loss with these drugs. So 25% of a person's starting weight can be lost within 1 year of treatment with some of these drugs. So what are they? Here are some of their names. You will have heard some of them, of course. And I think a couple of interesting points. Some of them are given as subcutaneous injections, but there are new oral tablets being developed and in clinical trials. And these drugs can target either 1, 2, or even 3 of these different receptors for these incretin molecules. Here's some of the trial data. On the left, you can see some of the seminal data for the use of semaglutide. That's also known as Wegovy, and it was launched just about September, October last year, and is now available in the UK through specialist services. And you can see that the kind of level of weight loss that was being seen was about 15%. There's a lot of excitement around tirzepatide, which is a dual agonist, and you can see here that the level of weight loss we're seeing here is about 20%, and when it's combined with strong dietary and physical activity advice, even some people are losing around 25% of their starting weight. So this really has the capacity to transform the health of patients, substantially improving all that long list of conditions I talked about at the very beginning. This is a very complex slide, but it's really the headline that I wanted to emphasize, is that after showing that the drug was very effective at helping people to lose weight, one of the key things people wanted to know was, what about all of the complications that people get? And the big one that we were interested in was cardiovascular disease, because it's the major cause of death in people with obesity and diabetes. And a number of trials have now shown that actually people who are treated with these drugs have a substantially reduced risk of a major cardiac event. If they already have had one event, their chances of a second one are reduced by about 20 to 25%. And that happens if they have diabetes or even if they don't. So this is actually a massive finding, because this really has the potential to substantially improve the lives of people with obesity, with and without diabetes. So really, this is just my summary where I was trying to put everything together that we know. And really, I think this is not only transforming the treatment of obesity, but I hope should transform how we think about obesity, and that we recognize it's clearly a clinically significant problem for a lot of people. And we now have ways of helping those individuals to have healthier lives. So obesity is when you have too much fat that adversely affects your health, and the system for regulating weight is not working as effectively as it should do. Diabetes is defined as having too much glucose, where the system for regulating glucose is not working as well as it should do. And clearly, in all of us, these conditions arise from a combination of our genes and the environment. But it's important to realize that it's both things. Now, what we've learned by finding the genes for obesity is that the major way in which they work is by affecting our hunger, our food reward, how much we crave food, and how full we feel. Our genes explain why some people have a big appetite and some people have a small appetite. That's really important to understand, and really I hope should start to dispel some of the blame that is faced by people with obesity. Now, when it comes to looking for genes for diabetes, they actually work in a different way. They work basically on our fat. So, for example, in some people can gain weight and they might not develop diabetes. Other people develop diabetes when they may not even gain so much weight. And that's because our adipose tissue, our fat tissue, can't expand to handle that extra fat. And so the fats spill over and go to the liver and the muscle, and they impair their function, causing diabetes. So I've just put some numbers on these different parts of the system, and you can see that the medications that we now have for these two conditions target different aspects of the system. And that's very exciting, because the body is a complex thing, and we're going to need medications that target different parts of the system, just as we have for blood pressure, for asthma, and for other conditions. So really just finishing with my final slide, that I think it really is a very key point in medicine, actually, where we're now transforming the care of people with obesity, using scientific knowledge to develop new medicines, and I hope also to develop a more sympathetic understanding of the problems that people face. Some of the things that are going on, and Cambridge is playing a leading role in much of this research. There are new trials going on of higher doses of these medications. There's a lot of interest in combining medications to see how you can get a good effect. There are a significant number of young people with severe obesity, and there will be trials in adolescents, including one that we will lead here in Cambridge. There are trials looking to see if treatment can improve, and how far does it improve these many different comorbidities that people have. And interestingly, these drugs seem to have more powerful effects, not just on weight, but on other parts of the body. And in fact, some of them are even being trialed in conditions such as dementia. And here in Cambridge, we're also going to be leading the next wave of trials. And that's basically something called platform trials, where you have lots of different drugs in one trial, so that you don't have to wait for each trial to be finished before the next one starts. And that's very exciting. That'll be led by myself and Professor Nick Wareham here in Cambridge. And we're really hoping to set something up that can be rolled up across the UK to really accelerate the innovation in this space. Okay, I'm finished. Thank you very much for your patience with the IT issues, and I'm very happy to take any questions.
Thank you very much indeed. That was fantastic. Thank you. Very clear as well. Thank you. And the slides are brilliant. We do have some questions, so I'm just going to work through them, ask them on behalf of the attendees. First one: is lifelong treatment required? Do people gain weight on cessation of the treatment? Does cancer risk reduce as well as MACE?
Great questions. Okay, so for cancer risk, we don't fully know yet. There's a little bit of evidence suggesting that colon cancer risk may be reduced, but I think it's been so early, we haven't really been treating people for long enough. We're quite keen to work with our colleagues, actually. There's a strong body of cancer researchers here, including those on cancer prevention. And so we're going to be working with them to answer some of those questions. Yes, people do regain the weight when the drugs stop. So that's one of the challenges. At the moment, the medications are licensed in the UK for 2 years. And of course, the concern is what will happen when they stop. A couple of different angles to that. I think for some people, particularly with severe obesity or where there's a very strong genetic driver, they may need to stay on the medications like you would for blood pressure medication or heart medication. For other people, it's likely that we may be able to take them off the medications and use other tools to support them. And Professor Wareham and colleagues here in Cambridge have a lot of interest in using digital and behavioral interventions to support people once they've lost some weight. So we're going to be basically testing that out to see what works best.
Thank you very much indeed. That was from Gary. That's a question from Rachel. How far away are we from being able to do gene tests on obese patients, and might this inform treatments?
You can hear me?
Yes.
Okay. So we can do gene tests. So we worked for about the last 10, 15 years to try to get genetic testing approved in the NHS, and it is now approved. It is approved for people with severe obesity that begins in childhood, because that's really where we find the specific genes that cause obesity. If you like, you have different combinations. So in some people, one gene is enough to cause obesity, and those we can test for. It's available in the NHS, and particularly for people who've gained weight from early childhood. The other bit is that many people have a strong genetic risk. Okay, now that genetic risk is not one gene, it's probably hundreds of genes, maybe thousands of genes added together. Now, we can calculate like a score, which basically says people with a higher score are tending to be the ones who find it most hard to lose weight and gain weight most easily. At the moment, we don't know if using that score can be a useful guide to helping treat people, but that kind of research is going on at the moment.
Thank you. As they say, if you want a long life, choose your genes carefully, isn't that? That's the question number 3. Is there any reason why someone with type 1 diabetes wouldn't be prescribed these new weight loss medications?
Oh, you're on mute, Asada.
Sorry, this system keeps muting me every 5 seconds. I'm sure my team would like to do that sometimes. At the moment, it's really just about getting confidence in using these medications in different scenarios. These medications do work on the pancreas, and so it's not entirely clear whether it's a useful type of medication for people with type 1 diabetes whose pancreas is not producing enough insulin. It's likely that for people with type 1 diabetes, they do see weight loss actually, particularly if people have obesity as well as type 1 diabetes. But interestingly, and I mentioned it at the very end, there are quite a few different types of drugs coming out, and some of them work in different systems and therefore may be better for people with type 1 diabetes.
Thank you. A question now from Andrew Dooley. How does the use of medications fit in with bariatric surgery? Is the effect synergistic, or does having surgery add minimal benefit, even prevent the drugs working?
So surgery is very effective, and of course for a long time has been the only really substantially effective treatment that we've had. The kind of weight loss that we're now seeing with these medications is getting close to the levels of weight loss we could see with surgery of around 20 to 30%. So surgery still has a place, and it may have a place in different scenarios, for example, where you might need weight loss quickly because of other health problems, in people who may not be able to tolerate these medications, etc. However, I think that the whole setting has changed with these medications. So I think surgery still has a place, but I think it will change.
Okay, thank you. Sorry, you're mute again now.
Yeah.
There are trials to see if these and other medications may be useful in people who haven't lost that much weight with surgery.
Okay, thank you. A short question from Neil Adams. Why not just give people leptin? Question mark.
Good question. People thought that at the very beginning. And the reason is that most people have plenty of leptin, so giving them more doesn't really do anything. Leptin really is only, it now seems, useful in that relatively small number of patients who have no leptin at all. That is the children that I was looking after and treating. And their giving leptin is transformational, but actually it doesn't work in the rest of the population.
Okay, thank you. Next question, are there can there be any significant side effects of these from these drugs?
Yes, these drugs do have side effects, and the main side effects tend to occur when we start the drugs. They tend to cause nausea, sometimes abdominal pain. They work on the gut, and so the gut gets sort of activated in a big way. We can usually manage them by gradually increasing the dose, or sometimes holding the dose at a certain level and then building up gradually. But for some people, and it can be up to 10 to 15% of people, they can't tolerate them, and then they have to stop them. So yeah, as with all drugs, there are side effects, but actually we generally find that people can tolerate them quite well.
Okay, thank you. Next question from Rebecca Fahy from Cambridge. It's fantastic that we have new medications to use in the management of obesity, but given prescriptions of these are only likely to be for 2 years, would you also recommend bariatric surgery in the long term?
I think it depends from person to person. So I'd be very cautious in terms of giving anybody advice, without knowing them or seeing them, because it depends on an individual's kind of health setting. I think the 2-year cutoff point is going to change personally. That's my personal opinion, because I think it is just based on the trial data that we have. And I think as that trial data accumulates and as the clinical experience accumulates, it's likely that it will be changed. So I think at the moment, the general advice is that these medications would become the first line. And then in people in whom they may not work or they may have other problems, then one might consider surgery. But I think the 2-year thing should not necessarily be used as something to worry about at the moment.
Okay, thank you. Next question, also talking about side effects. There's been a lot of media speculation and coverage as regards to Ozempic, specifically the adverse effects from these medications. What do we know about the side effects?
So yes, so obviously we've talked a little bit about side effects. So the common side effects are really nausea and gut problems like diarrhea and things like that. I guess one of the things that I would say is that a lot of the media interest, as you will all know, about Ozempic in particular, and because it was the first one, were because effectively these drugs were being taken by celebrities and other people who don't have a significant weight problem. So it's almost like misuse or abuse, using the drug not in the setting for which it's intended. So I think one has to take that with a pinch of salt, because I think some of the people who were using these medications didn't really need them. And I think that's extrapolating that to people who actually do need them and have a health problem is a different thing. Like with any medication, we have to be careful, we have to gain experience of it, and we have to monitor people. And obviously across the UK, doctors will be doing that. But already we have pretty good data from our colleagues in the US and around the world.
Thank you. Next question for a guest. There's more evidence coming to light suggesting that GLP-1RA drugs have anti-inflammatory properties. What's your take on this?
Yeah, I think it is really interesting. And so I didn't go into this in a lot of detail, but the primary effect of these drugs is on weight, but there is good evidence in animals and others that these drugs have anti-inflammatory effects. So I think that evidence is real. And I think it's very exciting. And there are now quite a few things converging whereby people are thinking about using these drugs in other conditions, including in a trial in dementia. But also there are drugs that have been developed for inflammatory conditions where I'm being asked to look at them because they're clearly causing weight loss. So there clearly is a very big overlap in how inflammatory conditions and weight-related disorders work and when they go wrong, and the drugs that could be used to treat them. So I think that's a very exciting space. And I think we will learn a lot in the next few years.
Thank you. Next question is quite long, but I'll read it. For type 2 diabetes, Dr. Eric Westerman is successfully treating patients and reversing diabetes with low-carb diets. Are low carbs the key, and not the calories, according to the carbohydrate insulin model? Where are these novel drugs tested in people and under low-carb models?
Right. Okay. So there's a couple of different points in there.
Yeah.
So clearly, low carb diets and low calorie diets, when adhered to, can be very effective. And there's obviously very good data from our colleague Roy Taylor in Newcastle, demonstrating that in some people who were able to sort of stick to a 800 calorie diet with shakes and meal replacements, for example, that they could lose quite a bit of weight, and that did not only improve their diabetes, but sometimes remove their diabetes. So yes, that level of caloric restriction can be effective. Of course, it's very hard to adhere to, and it's often hard to maintain. Then there's a separate question about low carbs. So this is a very big issue of debate. I would perhaps draw the colleagues to, there's two very nice commentaries that were published last year. Kevin Hall is the lead of one of them, and I'm on that one. But essentially, there were almost like two rival camps proposing the evidence for and against the low carbohydrate model. And I guess, where do I sit on it? I sit with the fact that I think there's very little convincing evidence that that is the predominant way in which the system works. Clearly, what we find, anecdotally, and the trials show, is that some people do better on one diet, and some people do better on a different diet. I think that just is down to the variability amongst us. I don't necessarily think it tells us that one system is better than another.
Exactly. I think we may get to the point soon where we'll have to answer the questions after the event. But I've got one question I'd like to ask, if you don't mind. These treatments are amazing step forwards, but how accessible will they be to the general patients, and how long will that take to really come through to fruition?
Yeah, so this has become a big challenge. And so this has occurred for several different reasons. So you will have heard about this, and any patients who are listening in will be very aware of this. Basically, these drugs were licensed last year in the UK, and they can be prescribed in specialist services. So that we've hit a few problems with that. Firstly, the specialist services in Cambridge and elsewhere were actually very oversubscribed already, and unable to see all the patients that they'd like to see. And now, of course, there are many more patients who could be treated with these drugs. So there's a problem around the UK in people not being able to get to see the specialists who could prescribe the drugs for them. We are actually trying to work with CUH leadership team to try to see if we can develop some solutions for patients in this region, to work with our colleagues in the existing obesity clinic and try and get access to a wider number of patients, and then hope that something like that could be rolled out across the UK. The second issue that we and others have had, which again you may have heard of, is the supply of the drugs. Okay, so fairly soon, you may remember when some of Ozempic was first made available, people could get it from private healthcare providers at the same time as it was available in the NHS. And what happened, no one seemed to have predicted, but I think it's fairly obvious it would have happened. There was huge demand. And so essentially the supplies went right down. Also, actually, to be honest, there's been huge demand in the US, and most of the global supply is going to the US. So there's a lot of complex politics involved, but some of those issues are now being addressed, and the supply to the UK is getting better. So, and I know that at a very senior level that there is a big move to sort this out. So I hope the supply issues are being sorted out. As you will have heard, I think their companies are building factories actually because they cannot keep up with the demand, and they're also having to build factories to make more pen devices. So there is a supply issue because the demand is huge. I think the situation is getting better in the UK and will get better within the next 6 months.
Thank you. I think we've got time maybe for just one more quick question. This is from Charles. How do drugs compare to surgical treatments? I know that's a big question, but just as an overview.
So, I mean, the drugs are getting close to the level of efficacy of surgical treatments. So if a bypass surgery works, the amount of weight loss people are getting traditionally has been somewhere between 20 to 25, 30%. Some of these drugs are now getting close to that level of weight loss. And of course, without the major surgical procedure.
Great. Thank you very much indeed. I think we're coming up to 7:29, so I think probably we also end now. But certainly, I'd like to offer my thanks. I'm sure the thanks of everybody on the call for your very detailed, incisive, and important presentation this evening. Very, very interesting and very, very important as we all need to get fitter. I'd be grateful if people, as they log off, there's a survey that's at the top right hand corner of the screen. If people could click on that survey, that would be very useful. There'll be a recording of the webinar that would be posted on the CUH website and also on the YouTube as well. So please look at that and maybe share that if you get a chance. And I would reiterate what I said right at the start. Certainly, we are keen for more members to join the trust. It's very easy. And please do get involved in the governance elections if you have any interest in the health service in the region. So finally, thank you all for dialing in. Thank you for our excellent speaker. Thank you very much indeed for the organisation by Namu and the team. And I hope you all found it enjoyable. I certainly did. Thank you.
Thank you.